So, good evening. Am I audible enough?
Yes, sir.
Okay. And the screen is visible?
Yes, sir.
So today I'm just going to talk as a continuum of the ectopic endometrial gland tissue location, which is now no longer confined to the uterus, but is now confined, has actually gone beyond the confines of the uterus into the pelvic peritoneal spaces. Not just in the pelvic peritoneal spaces, they can also go into the or the abdominal peritoneal spaces, the abdominal subperitoneal spaces, and even extraperitoneally into the retroperitoneum or even into the anterior or the posterior abdominal wall. So the location of this endometriotic tissue, depending on where it's going to be in terms of either in relation to the uterus, into the bowel, you'll have bowel endometriosis. You can get hepatosplenic endometriosis, especially along the hepatoduodenal and the gastrohepatic folds. Bowel can be multifocal or multicentric, and I'll explain those terminologies as I go on in the session. You can get it in old operative scars, which could be in relation to the bowel or the solid or the hollow viscus itself, or even within the anterior abdominal wall. And also in very unlikely situations, they can go beyond the confines of the endopelvic fascia and be located in very odd locations like the pelvic side wall, the gluteal region, and so on and so forth. What I'm going to do is, again, I'm just starting off with the normal anatomy. And yesterday, when I was talking to you all, I kind of used a very important tool to explain to you all when you're looking at anatomical conformity of structures. What I mean by this is, and it's very important, not only in abdominopelvic imaging, but whether you're doing head and neck imaging or neuroimaging, that what is a normal appearance of a structure. So the normal appearance of any structure in the body is based on a lot of features. Now, those which are purely intrinsic to it would be naturally the contents of the observation or the structure itself. And of course, therefore, you get particular signal intensity characteristics. But more importantly, what is the impact of that signal within in terms of the contouring and the morphology of that normal structure? So what I mean by that is you should know the normal morphometrics of that structure to go and start to say whether that is normal or not. And I find that the most challenging thing to give in radiology is actually to give a normal report. And that's the most difficult and the most scary one. I often tell that to my resident doctors as well as some of my junior faculty, that it is extremely challenging when you know that a patient has come for some pathology and you're going to give out or sign out a normal report. So please remember, learn to identify what is the normal morphology, morphometry, contouring of a anatomical structure. Okay, so just give me a second and I'll just use some keys and I'll, one second, sorry. I'll just move this to one side. Sorry. Yeah, I've put that down. And here we go. So when I'm looking at the morphology of the corpus, and this is a normal antiverted, antiflex corpus, and I'm not talking whether it's bulky or not, that's a kind of a ludicrous term to use. The thing which has to be very keenly maintained is that this contouring, which you're seeing from the fundus to the posterior wall, going up to the uterocervical junction, and then going on to the posterior lip of the cervix, is usually a lovely C, depending upon the level of antiversion of the corpus itself. So by and large, this is a standard morphology of the, and this is what you need to identify. The same way, so you tend to get an outward convex or a more rostrally or a more posteriorly oriented convex curvature. Now that is very important to remember because any change in this contouring, so any tenting, any focal protrusion is going to cause a lot of issues when you're trying to see whether what is the anatomical structure causing that tenting or tethering of the lung. Now, what I mean by tenting, have a look at this. If suppose this is the change in the morphology of the corpus, if I see this kind of an approach, that means the posterior wall is getting pulled up by some structure. I need to be very, very careful. Another form of tenting would be Suppose rather than having a pure convex bulge, you see an abrupt concavity, and then you see rolling up of the lower portion of the uterocervical junction. Now, when you see this, it means that there is some kind of a structure which is really pulling and tethering it along its surface, and therefore it's contracting either ends of it, causing it to now not be an antiverted or an anti-flexed corpus, but could be an acutely retroflexed corpus which is sitting up over there. So please remember this normal contouring, especially the posterior wall when you're looking at antiflex uterine structures, and the anterior wall when you're looking at retroflexed uterine structures. Very, very important to remember this. Also, please remember that here you can have diseases which are not in the endometriotic spectrum. They're intimately related to the peritoneal reflections. And we already know that the peritoneal reflections do not cover all the organs of the pelvis in its entirety. So there's a lot of organs which are intraperitoneal, a good number of them which are subperitoneal or retroperitoneal, and then of course you have the extraperitoneal structures itself. So that's something which you really need to identify. Now, when you're looking at, therefore, when you're looking at the corpus and you're dividing it into its peritoneal and subperitoneal compartments, you also need to identify a key structure similar to what you identify in rectal cancer imaging, and that exactly is the level of the peritoneal reflection in relation to the posterior lip of the cervix, and therefore the posterior fornix. Now, that's very difficult sometimes if all the pelvic loops are all kind of fecal loaded, or they're compacted into a very small space, but occasionally you're able to pick up that peritoneal reflection, like especially we have to do that in rectal cancer. And by and large, the peritoneal reflection is seen at the level just above the torus uterinus. Now, the torus uterinus is a kind of a structure which is located along the posterior wall of the uterocervical junction and the upper third of the cervix, which gives attachment to the uterine end of the uterosacral ligaments. Now, what happens is the peritoneal reflection is located above the uterosacral ligaments. The uterosacral ligaments are condensations, which basically are posteriorly and attached to the sacrum, and they give the tug onto that sacrum itself. Now, why is it so important to know these structures is because though endometriosis is initially a peritoneal disorder, if the peritoneal, if the same pathology starts infiltrating the peritoneum by a depth of more than 3 millimeters, it no longer remains to be purely peritoneal, and it starts to become subperitoneal. And the classic location where the subperitoneal location of the disease is at the level of the uterosacral ligaments. Okay, so just give me a second and I'll just start sharing the pathological case. Okay, so I'm going to start off with the first case just to make you guys understand normal contouring. Have a look at this. So look at this. This is a normal contouring. I'm going to draw it all over again. Look at that smooth C, which is kind of forming off. At the same time, look at this case sitting up here. You can see the normal orientation of the cervix to the vagina. However, the corpus, instead of being classically antiflexed, is somewhere mid-position. It's neither tilted completely posteriorly, neither gone backwards, but there's this terminology called acute posterior tipping of the fundus. Now, ideally, this fundus would have been somewhere here, but there's something which is causing this change in the morphology of the fundus. So if I'm going to contour this structure, going up from the fundus to the posterior wall, you will find out what I'm trying to show you. So what I had taught you on the previous study, on the initial part, that if suppose there is something which is dipping the contour in, it's going to cause the fundus to move in a different direction. So if I were to kind of show you which way the fundus would start moving, the fundus would move upwards. So the fundus, instead of being low, is going to be pulled up here because of the tug sitting out here. And at the same time, the posterior fornix, which is located here, is going to move upwards as well. It's going to move in this direction. So when you have this kind of a movement or this kind of a tug along the posterior surface of the uterus and the corpus, the first thing you got to realize is that there's something along the surface of the uterus, or there is something else which is tethered to the uterus, which is causing this contraction and reducing the space between the structures. And as it's causing this mechanical contraction, it is causing this very unique phenomenon called acute retroflexion or retrotipping of the fundus, along with postero-superior retraction or migration of the posterior fornix. So ideally, the posterior fornix should have been located here. In this case, the fornix is located very, very high. This is an abnormal case. This is an abnormality. So you can appreciate the differences, what's happening in both the cases. That's a normal corpus. Here you can see there's something abnormal going on at this point in time. Now, don't worry too much about this. This is a classic C-section scar. So you know this is the lower uterine segment. This is the internal os. This is the cervix. So you can see that there is something which is causing this acute concavity of the posterior surface of the corpus. So let's see what exactly is this concavity. So now this is where you need your your visual cues to be very, very sharp. When you look at the surface of the anterior wall, anterior serosus surface, and compare it to the posterior serosus surface, you find that there is an abnormal thickening of the posterior wall of the lower of the uterus, as well as the upper third of the cervix in this location. Now, this thickening, you don't get that normal smoothness. You see that? You're seeing this abnormal thickening, which is sitting up here. If I were to just put it up here, you can see the disease very nicely. You can see an abnormal thickening along the posterior serosus surface of the corpus. So when you're seeing this abnormal thickening, you got to start realizing what the hell is this going on out here. Now, this thickening is, if you look at it from a signal intensity point of view, it's kind of an intermediate to what I would say a darkish gray kind of a structure. And I'll put that on the actual images. You can appreciate that here. Setting up here. Now, this structure is kind of darkish gray towards, you would say, a blackish color, which you're seeing out here. And you know what, you might think, okay, this is a plaque or a band-like thickening along the surface of the corpus. And you would say that it's retrotipping the fundus, it's retracting it. So it's definitely not something which is active. If something which was active and it was like a tumor sitting up there, it's very unusual for it to have a plaque-like configuration or a plaque-like morphology. Most of the time, when you get tumor sitting there, you will have nodularity. You will have a lobulated or a lobulo-invasive morphology. You're not getting to see that at all. What else are you seeing? Along with this, you're seeing some very unusual changes in this structure, this place called the rectouterine pouch. So the rectouterine pouch is basically a deep sleeve of peritoneal reflection in the pelvis, which is insinuating behind the corpus and between the anterior wall of the upper rectum. Now, the depth of this pouch is very variable, and therefore, it is delimited by the lowermost site of the peritoneal reflection itself. In some patients, it can be a very high pouch. In some patients, it can be a very, very low pouch. Now, in this case, what you're seeing is you're not seeing the normal pouch coming up here because it's kind of partly obliterated. And if you look carefully, you can see these kind of wisps or band-like structures which are emanating from that plaque-like thickening on the surface of the corpus into the rectouterine pouch. Now, that thickening which you're seeing here or you're appreciating out here is now gone and partially obliterated the pouch, is affected the endometrial, the peritoneal reflection, and has taken out that pouch partially. Now, I won't get too much into what else is happening. That's for some few later cases. But this is where the T1 weighted sequences, which is usually fat suppressed, will help you identify what is going on at this location. So let's look at this T1 weighted sequence. And if you see, this is kind of not exactly a match, but this is a three-dimensional sequence. This is a two-dimensional sequence. You can see the rectum, which is fecal loaded, sitting up here. But now if you look carefully at this location, which you're coming through, this is where the corpus is, you'll start seeing areas of bright signal coming up here. So if you look at this, this is where you have the intermediate gray to dark T2 thickening. And the same patient, you have areas of brightness embedded within. And this is a T1 weighted fat suppressed sequence. How do you know that? You can see that the pelvic peritoneal and the subperitoneal, the subcutaneous fat in the ischial fossa and the gluteal region have been suppressed. So when you know that you have something which is brightish sitting in this location, you kind of know that you're looking at something which is non-fat, which is still remaining hyperintense on the unenhanced T1 weighted fat suppressed images. Your differential is going to be blood degradation products or alternatively mucinous matrix. Now, why would mucinous matrix come in this location? It's a very unusual location, which is going to be for mucinous matrix. You do get them, of course, when you're doing when you have pseudomyxoma peritoni, of ovarian origin, or appendicular or colorectal in origin. But here there's no other ancillary finding to support the diagnosis of the malignancy. So what you have is a plaque-like thickening. When it's so dark or intermediate, you would think it's fibrotic in nature. But within that fibrotic plaque-like thickening, you're seeing specks of T1 brightness all along the surface of the corpus. So now you're going to kind of put it all together and you're going to say this could be hemorrhagic, but the entire lesion is not hemorrhagic. It's predominantly fibrotic, fibroinflammatory cicatrization with certain areas of blood within. Now let's see what's happening, first of all, to the corpus, and then what is happening to the surrounding structures. Now, these are important. I'm going to spend about 10 minutes on this case and then move to the other ones. So let's look at the corpus itself. So yesterday I had kind of shown you all the terminology of adenomyosis, which is either focal or diffuse broadening of the junctional zone. And isolated junctional zone thickening is a very complex topic. There's no definitive way to actually differentiate that from a pre-adenomyotic patch, especially in the reproductive age group. The variations in the junctional zone can be as much as 2 millimeters to 20 millimeters. So if there is focality, there is contour bulge, there's deformity, yes, you know that this is highly likely. Alternatively, if you start seeing dilated endometrial glands within the junctional zone thickening, that's more of a sine qua non feature. They could be hemorrhagic or non-hemorrhagic in nature. However, there is a propensity. So that's typical uterine adenomyosis. But when you tend to get this kind of a picture where you get hemorrhagic and fibroinflammatory tissue coating the serosal surface of the corpus, there's a tendency for this hemorrhagic endometrial gland sitting up here to invade the subserosal uterine myometrium. So if you see very carefully in this patient, the junctional zone is pretty much normal in thickness. It's not more than about few millimeters. However, if you see discontinuously in the posterior wall, there's an inhomogeneous signal which has come exactly below where that plaque-like thickening is situated. And this is actually subserosal myometrial infiltration of endometriotic tissue. And that endometriotic tissue is going to look exactly similar to adenomyotic tissue, which is where you have broadening of the junctional zone. So though this does fit into broadening of the junctional zone, it is not a true adenomyosis which you're seeing. This is pseudoadenomyosis, or what I call as subserosal posterior or anterior myometrial infiltration of the endometriotic tissue. Now, if you look at this, the endometriotic tissue can be either active or inactive. How do I know whether that tissue is active? If there is areas of active T1 hyperintensity seen within it. So when it's actually bleeding, you will actually see those bright specks within that subendometriotic tissue within the posterior wall. If this was a quiescent or a chronic disease state without evidence of much of estrogen support, not much of T1 hyperintense signal, you know that's a quiescent adenomyotic area, which is seen in this pelvis. So here you can see how aggressive this so-called benign looking tissue can be. It can not only go outside the uterus, but from outside the uterus, it can erode and get into the posterior wall itself. Not only does it get into the posterior wall sitting up here, but it actually kind of goes in and tethers onto or even infiltrates the posterior wall of the cervix. And when it does so, it kind of pulls up the fornix. So you can see how high the fornix is located as compared to the anterior fornix. So, and you can see the so-called tenting, this kind of an appearance of the cervix, which I'm kind of showing out here. This posterior tenting of the cervix is pretty much sine qua non for a pathology which is located along the uterocervical junction at the level of the uterosacral glands, ligaments. So now let's see, when I've shown you what's happening to the area of the torus, to the subserosal myometrium, now let's see what happens to the uterosacral ligaments. And if you see very carefully, these are the uterosacral ligaments. I'll just kind of annotate them for you. That's the uterosacral ligaments. That arc-like structure which is coming up, it's like a handlebar mustache, only thing it's kind of invertedly located. And that thickening is where you're seeing it emanating all the way from the uterocervical junction. You can see where the crosshair is going through. That's a typical location of the uterosacrals. And you can see that the uterosacral will be tethered, contracted, and you'll not be able to get the ballotability of the uterus because now the ligaments are kind of fixed and it's not going to allow you for movement. So what do you have now? So you have disease along the posterior surface of the corpus. You have seen subserosal posterior wall infiltration with pseudoadenomyotic appearance, the change in the contour of the uterus, and you're seeing that now the disease has gone below the peritoneal reflection, taken out the uterosacral ligaments, and the depth of invasion is usually more than 3 millimeters. This fits into the classic definition of deep pelvic endometriosis. Now, deep pelvic endometriosis has got many subtypes. You have that based on the compartments which are available. So what are the compartments? The compartments are the anterior compartment, very much similar to what you see in the perineum. So you have the anterior compartment, which comprises primarily of the urinary bladder, the urethra, and you have the vesicouterine shelf, which is a very important structure. The mid compartment is typically the uterus with the cervix, and of course the broad ligament complex and both ovaries, which form part of the mid compartment. And the posterior compartment is the rectovaginal shelf, along with the mesorectal fascia, mesorectum, as well as the upper mid and the lower rectum per se. So these are compartmentally there. So the first case which I've shown is a classic mid-compartment deep pelvic endometriosis, typically along the posterior serosal surface of a corpus, causing the acute retrotipping of the fundus, subserosal infiltration, and obliteration of the rectouterine pouch with involvement of the uterosacral ligaments. What else do you see in these patients? The next thing which you see, which if you remember, I showed you these band-like structures which are seen at the level of the peritoneal reflection and above it. And basically what's happened is the rectouterine pouch has got partially obliterated. Now, what else do you see? Other than just the thickening, you actually see something very unusual, is that there is a tenting of anterior wall of the upper rectum. Now, this is pretty much a very sine qua non imaging feature of a terminology of a condition in DPE, which can happen in any chronic inflammatory condition, and that's what we call as frozen pelvis. And what happens is these fibrotic or fibroinflammatory bands tether the anterior wall of the rectum and bring it very close to the retrotip fundus or the retrotip posterior wall, and you get this kind of a kind of a typical imaging feature of the tenting of the anterior wall, and you tend to get a lot of adhesions in and around this thing. So the rectum tends to get adherent to the posterior wall of the corpus itself. What else do you get? If the endometriotic disease is little more proliferative and extensive in the pelvis, it tends to not only affect the rectum, but it also tends to tug onto the broad ligament complex and the ovaries. And the ovaries are also now no longer located floating in the pelvis or ectopically located in the lower abdomen, but they're actually pulled down, and they're pulled down into the parauterine spaces. And these parauterine spaces are seen very conveniently on the axial T2 weighted images. And you can see that both ovaries are now no longer free floating in the pelvis. You don't have that intervening fat plane, but what you have is that broad ligament around the ovaries are wrapped around and kind of plastered to the lateral, the posterolateral surface of the uterus. And you can appreciate how there is this thick endometriotic tissue with fibrotic scarring, and you can see how it has kind of coated the medial surface of this ovary out here, and the ovary is kind of pulled or tugged inward. Now this, along with the rectal tethering, is a classic finding of what you get in deep pelvic endometriosis, and we call that the frozen pelvis. So the first case, kind of what I tried to show you was enunciate you into the basic changes in the contouring, the morphology of how the lesion looks on MR, and what else tend to get with the gamut of pathologies going on. So what I'll do now is, rather than showing you some cases, I'll show you a couple of presentations of the disease in a clinical form, and then we can go and take it ahead in terms of how this usually tends to present in clinical practice. So let's see this case out here. So we have a patient in her early 30s, you can see. I'm doing the CT. CT is not usually the way we actually assess the pelvis. For us, we do MR in every pelvic pathology as much as possible. And this patient actually presented with actually a perrectal bleed. And I'll show you the sagittal recons rather than complicating the whole stuff. And if you see the sagittal recon, it's got a pretty sinister look to it. So if I were to kind of identify all the structures, that's the anal verge, that's the anal canal, that's the levator shelf. You can see the upper rectum, which is sitting, the lower rectum, which is sitting on the levator itself. That's the mid rectum, and you've got the peritoneal reflection somewhere here, and this now becomes the upper rectum. So that kind of makes it pretty much easy. And when you're looking at this, you're kind of given rectal contrast in this patient. And on administering a rectal contrast, you see an eccentric proliferative lesion along the anterior wall of the upper rectum. How do you know this is upper rectum? Ideally, the upper rectum kind of ends at the level of the S1 segment, and you have the beginning of the rectosigmoid, which is starting up here. You can see that kind of convolutedness of sigmoid coming up, with the valvulae also seen there. You can see the valvular appearance here. The rectum doesn't have that. It's more capacious. So what do you have here? So you have a pathology which is eccentric. You can see that the posterior wall and the lateral walls are spared, and the lesion is kind of partly lumen encroaching. So you can see a residual lumen sitting up here. As I'm moving through, you can see this so-called kind of a semi-apple core appearance, central wasting. And you're going to start thinking that this is going to turn out to be a rectal adenocarcinoma, and this patient is going to be warranting some kind of a further imaging with MR at some point in time, or even with a PET CT if required. So you'll have MR, PET CT, and the whole gamut of things coming up. And she was presenting with rectal bleed. But what was unusual also with the same patient was not only were you having thickening, but you were seeing bilateral adnexal mass lesions. And these mass lesions were not normal attenuation. So you would not see, when you're seeing normal ovarian attenuation, it's more fluid-like, simply because it contains density of fluid usually in the range of about 2 to 10 HU. As the density of any fluid-like structures tends to climb about 20 HU, it's no longer serous fluid which you're looking at, but you're probably looking at an evolving fluid which is either proteinaceous, could be hemorrhagic, or is just a very turbid collection. So once you get to see ovarian or adnexal lesions on a plain scan where the HU is more than 20 or more, you need to start thinking that we're not looking at simple ovarian cysts. Of course, in a minuscule number of patients, you don't want to be missing solid ovarian lesions which have mucoid matrix within, like Krokenberg's or even primary mucinous tumors of the ovary. So by and large, what you get to see right now in this patient is rectal wall thickening, bilateral adnexal lesions. You don't see the native ovaries separately, and you're not seeing any pelvic side wall adenopathy. Now that's pretty unusual. If you're going to start thinking this is rectal cancer of this size, you would start seeing nodes in the perirectal space, and you will start seeing nodes along the pelvic side wall of this size lesion. So now you've got to start thinking what's happening. And also what you notice is both ovaries, though they're so bulky and large, they're kind of plastered laterally to the uterine surface. So you can see that the ovaries both are kind of plastered to the uterus per se. So now let's go and see, when we did the MR, what was the appearance of this pathology. Just give me a second. Sorry, 1 second. So here we go. One second. The right scan. Okay, so here we go. This is the MR of the same. And to our surprise and to our delight, we were pretty much right in the way we were thinking. This patient basically had a lesion in the anterior wall, but interestingly, you could see that on the T2 weighted images, axial, which are coming down from the fundus, you can see that there are two bulky ovaries sitting up here, the contents of which are pretty much sine qua non in imaging, which I'll start describing to you all. And as we also expected, we found that the lesion in the anterior wall of the rectum was tethered to the posterior wall or the posterior serosal surface of the corpus itself. So now what we had was, in a young lady, you had a rectal lesion with bilateral adnexal lesions along with extensive tethering and fibrosis, which has caused what we call the typical frozen pelvis appearance imaging on the MR scan. Now let's kind of try to decipher how this kind of looks on the T2 weighted image. So what I'm going to go back, I'm going to do this case again in detail, and then I'll run through with the remaining cases. So just give me a second. Again, just for the sake of completion, that's a normal corpus. Please concentrate on the thickness of that signal intensity along the posterior wall, and let's look at it, what's happening here. In this patient, and that's the area which you want to really concentrate on. I'll kind of demag the image, sorry. So concentrate on this area. Yeah, that's the only thing I want you all to concentrate on. The first thing which you start noticing is the blackening. And you start seeing those areas of blackening along the posterior serosal surface. You can see that lumps and bumps and that irregular contour of that uterine serosal surface. You know that there's something wrong going up over there. So what I do is I don't straight away run onto my T2s. I go onto my T1s. And the first thing I notice as soon as I put the T1s is that area which you had that bright signal on the T2 is actually corresponding to a very bright T1 hyperintense area. So you know this is going to be hemorrhagic in all likelihood. So you've got a hemorrhagic deposit there. If you start going a little more off center, on either side, you'll start seeing that there are a few more specks of hemorrhage along the lateral aspect of the thickening itself. So now when you've got these 2 points going in, plaque-like thickening, change in the contouring, without a mass-like lesion, multiple areas of T2 brightness just beneath the scar, one of which is very bright on the T1, you're probably looking at a form fruste of a mid-cul-de-sac pattern of deep pelvic endometriosis. So now when you see what's happening, your eye should straight away go to the subserosal myometrium in the posterior wall. That's a normal myometrium which you're seeing out here. You can see the normal myometrial signal intensity, and you can see the abnormal myometrial signal intensity sitting here. Basically, what happens is endometriotic tissue incites a fibroinflammatory response in whatever tissue it sits along with. So by and large, what happens is when the normal myometrium in the reproductive age group has got an intermediate to a grayish signal, it's never black. So when you see blackishness in the myometrium, there are 2 or 3 differential diagnoses. One is a fibroid, and the second one is adenomyosis. The third one is deep pelvic endometriosis infiltrating the myometrium itself. When you get to see a fibroid, they're relatively well circumscribed, they're lobulated margins, whereas adeno and the deep pelvic endometriosis invading the myometrium, both of them tend to have indistinct margins with the surrounding myometrium. Of course, how do you differentiate adeno from DPE? Is a relative sparing of the junctional zone. And if you look very carefully, it's very important to remember that this is the junctional zone. You can see the delimiter. This signal you're seeing out here is separate from the junctional zone, and it's not a sequelae of adenomyosis. It's just that the endometriotic tissue produces a desmoplastic or a fibroinflammatory response even in the myometrium, and you would call that a pseudoadenomyotic appearance of the corpus itself. So now you've got all the features which are now going to help you make the diagnosis. So what else you start looking for? The second thing you start looking for is what the hell is happening to the ovaries. So now I've got both the ovaries sitting up here, and I put up the T1 weighted images just to make sure what we have. And when you look at this kind of an appearance, imaging appearance is sine qua non. You get structures which are bright on the T2 weighted image, the contents of which are bright on T2, bright homogeneously on the T1. And if you look carefully, there is what we call a shading effect. You can see the shading. It's not jet black. It's somewhat grayish in signal, and you tend to get a variegation in the signal intensity of that structure. Now that is called a T2 shading effect. And that T2 shading effect is pretty much a sine qua non finding of the presence of a hemorrhagic lesion. Now, what is the differential diagnosis for a hemorrhagic lesion on MR? Can anybody tell me that, if anybody can? So when you have a hemorrhagic lesion in the ovary, the first differential is, of course, it could be a simple hemorrhagic cyst. Of course, the differential diagnosis are going to be an endometrioma. Less likely, very rarely, you've got to remember endometrioid carcinoma of the ovary. That's one differential which you should always keep in mind, which can occur in these patients itself, and they can also show a T2 shading effect. Now, this T2 shading effect only does not affect every endometrioma. So you don't expect T2 shading effect to be seen in all cases. It only affects a minuscule number, or is only seen in a minuscule number of patients. And it's simply because of 2 reasons. It's the admixture of protein or myxoid matrix with the presence of iron of various ages, which actually occurs due to recurrent bleeds or rebleeds within these ovaries. And that shading can be very variable. So you could get it as such as a very subtle. If you look at this carefully, you can see a subtle shading effect coming here. You have a gradient, or it could be as dense and as jet black as you're seeing in this ovary sitting up out here. So therefore, now what do you have? You have a patient with endometriotic tissue along the posterior serosal surface of the corpus, the mid cul-de-sac, subserosal infiltration, obliteration of the rectouterine pouch, both the ovaries plastered to the uterus itself, and they all contain ovarian endometriomas. Both the ovaries contain ovarian endometriomas. Now, what else are we seeing in this patient? So as we saw on the CT, we saw that kind of a mushroom-like cap appearance. What you see? You saw a lesion which was seen within the anterior wall. It was kind of eccentric, primarily on the anterior wall, arcing onto the lateral walls. And you were thinking whether this could be a polypoidal neoplasm of the rectum itself. However, if you go back onto the MR, and if I put the T1 weighted image here with you, and if I run through this, and you note very carefully, you can appreciate that at the base, what happens is the lesion is not arising from the rectal wall, but actually the lesion is arising from the posterior serosal surface of the corpus, and it has kind of tethered the anterior rectal wall and infiltrated the rectal wall here at this location. So I'll move it onto the axial images, and you'll see it what I'm going to show it to you all. Actually, so it'll see best on the coronal. I'll just move it up. And you can see this lesion sitting within the rectal lumen out here. And you can appreciate how the gap is obliterated between the ovary, the corpus, and the rectal wall. And you can see those lovely fibrotic strands which are emanating from the surface of the corpus and are actually penetrating through and through the thickness of the rectal wall. Now, what do we have here? So this is a classic case of a mid-pelvic endometriosis, which has now infiltrated the rectal wall. And what you have is a mid and a posterior compartment presentation of deep pelvic endometriosis. As a radiologist, you need to identify three important structures here. A, is it only tethering the rectal wall? B, is it infiltrating the rectal wall but sparing the mucosa? Or third, is it infiltrating the full thickness of the muscularis and the mucosal lining and presenting as an endoluminal lesion? Now, based on these, the depth of infiltration, and of course, there are certain other criteria which are used, you need to identify and tell you what's happening to the rectum itself. So here, there are 2 points which you need to remember. Of course, the depth of infiltration, that's surface, muscularis, mucosa. That's the first thing you've got to remember. So this appearance, what we call a mushroom cap appearance, is sine qua non for transmuscularis mucosal involvement of the disease itself. So what has happened is the lesion has infiltrated the rectal wall here. It has kept on bleeding. And now what has happened is because it's incited a desmoplastic reaction, it has started to tether this wall, which is rostral to the site of infiltration, and the wall, which is caudal to the site of infiltration. It kind of puckers it. And as it starts infiltrating the muscle starts to hypertrophy and show also a desmoplastic reaction. And it produces the so-called mushroom, where you have a cloud-like appearance with the core where the point where it is actually infiltrated, getting to pucker completely. So this mushroom head with a narrow stalk is a classic imaging feature of full thickness invasion of the rectal wall itself. What are the other points you got to remember? Whenever you see rectal wall infiltration, you got to measure the maximum thickness and the maximum length of the lesion. Usually a cutoff, I think so, is about 2 centimeters is the first point when you're looking for the size of the lesion or the thickness of the lesion. The second thing is the percentage of the circumference of the rectal wall it has actually infiltrated. So as the lesion is eccentric, you've got to be very careful when you're measuring it. If the lesion is less than 30% of the rectal circumference, you can get away with the partial excision of that portion of the rectum. By and large, if it's more than 30%, you will require a resection and anastomosis of the entire segment and to maintain functional continuity with the anal canal itself. The third terminology you should always remember whenever you're looking at rectal or bowel endometriosis is a terminology called multifocality versus multicentricity. Now, multifocality is the same segment of bowel showing 2 or more sites of involvement. Multicentricity is multiple bowel segments showing involvement by endometriosis. Now, in this case, what we had of full thickness infiltration, and you had a little more thickening of the upper and stroke mid rectum seen out here, which is abnormal, which is again a multifocal site of disease involving the rectum itself. So here, what I've kind of shown to you all is in clinical practice, when you have a patient with perrectal bleed, it's very important to get the organ of origin. Very often in males, we have seen CA prostate invading the rectum, and CTs being reported this as a rectal cancer going into the prostate. Usually, it's very unusual for that to happen. It's more likely for the prostate to go into the rectum. Or the same thing can happen for pathologies of the uterus, where the rectal pathology may be secondary to something happening in the uterine corpus or on the surface of the uterine corpus itself. So this, why I've shown you this case is, this is how a classic clinical case works in your routine day-to-day practice. I'll show you another case which came to us very similar in terms of presentation. It's pretty interesting. This patient has had a prior surgery for uterine fibroids, and following the surgery 6 months later, developed an infection, and after that started developing regular pelvic pain, which was kind of cyclical in nature, but again had off late had started to become non-cyclical and was turning to be pretty profuse and pretty nasty for the patient, which really affected her day-to-day way of functioning. So what we have out here, I'm just going to show you the sagittal plane images in this case. And when I'm showing the sagittal plane, I'll first show you all the endometrial cavity. So this is the endometrial cavity. You can see that rim enhancement, which is seen in this. But interestingly, if you start looking at the cavity per se, and then you start seeing what's happening, this is the area 1 cornu laterally. I'll put this on actual images also for you all, just for the sake of completion. So you can see the cavity going up. But unusually, when you're starting to look at the cavity, it doesn't look normal at all. And when I'm running it through the center, you can see that there are multifocal hypoenhancing areas which are seen in the vicinity of the cavity, which are either communicating with the cavity or in contiguity with it, and they are moving up in a radial fashion. So they're moving outwardly from the cavity itself. So let me put this again on coronal. And if you see this, you'll appreciate what I'm talking about. You can see that there are these lesions coming up, which are radiating outwardly from the cavity, and they're going either into the posterior or the posterolateral myometrium, and they're reaching up to the serosal surface of the uterus itself. Now, this is what you get to see. And then from the serosal surface, as compared to the supravesical fat here, the fat plane posterior to the corpus is very, very fuzzy. Look at this. You get these linear strands which are running up, and they're radiating outwardly into that fat. And what you have here is the rectum sitting up here, and you have all these kind of linear twigs or these linear strands of enhancement or hypoenhancement radiating from the corpus surface. So I'll put this back on the sagittal plane, and you'll see this again. Corpus, which is normal in size, probably slightly bulky, and you appreciate these linear strands which are coming up here. So that's the imaging appearance on CT. Let's see what's happening to this patient when you put the MR. When I put the MR, oh, sorry. I don't know why it's happened like that. Let's see, MR images of the same. You can see this is a T2 weighted image. It's pretty difficult to actually identify what's happening on the T2. But what I'll show you all is the T1 3D first. If I do have the T1 3D, and this is the T1 3D. So if you look very carefully on the T1 weighted 3D images, what was looking like a normal hypoenhancing endometrial cavity is the cavity is now completely distended. It's not distended. The cavity is kind of compressed, and you can see that it's like a streak which is seen along the lower third, which is continuing with the endocervical cavity. But what else are we seeing? What were looking like rim enhancing, hypoenhancing structures within that myometrium or in the vicinity of the endometrial cavity are multiple confluent or conglomerate hemorrhagic structures which are kind of consolidating themselves in the vicinity of the endometrial cavity. So they're all kind of clumped along the margin. So this is the cavity, which is kind of compressed, and you see this bilobed hemorrhagic lesion. And if you note very carefully, all these kind of structures which are seen here, this is the site of surgery. You can appreciate the surgical site here. You can now appreciate how this hemorrhagic tissue has started to kind of radiate from the cavity or the center of the corpus and have gone outwardly and are now seen to reach the uterine serosal surface. So what else do you see? Now let's go back to the T2 weighted image. and kind of now make a note of what's happened. So just to kind of corroborate the same, that's the site of the surgical scar where you have the dimpling. That's the hemorrhagic lesions, which are very dark. But what is the signal intensity of that hemorrhagic lesion? Is it very bright on the T2, or is it showing something called a T2 shading? Yes, it's showing T2 shading, and it's homogeneously hyper intense on the T1 weighted image. And now you can appreciate how these tracts are leading from the cavity or in the vicinity of the cavity, dissecting through the myometrium along the prior surgical plane, which is now basically a tract which is created. And these foci have reached onto the surface of the corpus and are now gone beyond the confines of the endometrial cavity and are coating the peritoneal surfaces. Now look very carefully. The blood products are seen all over the ovary as well. So if I were to put this on the T1 weighted axial fat sat image, you can appreciate the tracts here. I'm running upwards, and you can see how the blood has kind of accumulated along the surface of the corpus, gone into the broad ligament complex over the areas of the fallopian tubes, and is now sitting on top of the ovary and also along the peritoneal reflection along the posterior surface of the corpus. This is a classic imaging finding, which we call as endometriosis in a prior surgical tract secondary to a uteroperitoneal endometriotic tract formation. So please remember, whenever this myometrial surgery is done, there are surgical tracts which created. If the endometrial cavity or the endometrial lining is disrupted, you need to be very careful in the future in follow-up to make sure that none of these endometrial or none of these surgical tracts are lined by this endometriotic tissue, because in the future that patient is now going to become a case of peritoneal dissemination of endometriotic tissue, which is iatrogenic in nature. So this is a classic peritoneal endometriosis, which you're seeing secondary to a prior myomectomy. And of course, please remember that they appear as on CT as tubular or tubular cystic ramifying tracts, which can go outward from this. So if you don't know the history, you don't have a background, you're very likely to even call that as probably infections. If you have an IUD device within the corpus, you're going to call it actinomycosis. You're worried for peritoneal dissemination of a uterine pathology. But in the right setting, you need to know that you cannot make the diagnosis on CT. You need MR to get you the diagnosis. So the first case was a classic peritoneal deep or a mid-cul-de-sac peritoneal endometriosis as the endometriotic tissue had come out from the fallopian tubes, the typical route of migration of endometriotic tissue. This is a classic case of uteroperitoneal dissemination secondary to an iatrogenic implantation of endometrial tissue along the surgical tract, reaching up to the serosus surface, and therefore now coating up to the corpus and also the ovaries itself. So please remember, the gamut of changes can be pretty much mind-boggling when you're looking at these conditions. Also, let's see whether this patient has got any kind of tethering or adhesions. And of course, you can see that the rectum has kind of gone in front, is kind of loosely attached. You can see that black band sitting up here, and you can see that focal tethering of the rectum as well. But it's not significant as much as in the previous case, because you still don't see any rectal wall infiltration or any abnormal signal within the rectal wall itself. So case number 2 is iatrogenic dissemination of endometriotic tissue into the peritoneal space. So I've finished this. Now what I'll kind of go through over the next about 25 minutes is the variants which you can start seeing. So I've shown you the mid and the posterior. I have to show you the anterior compartment. I'll just show you the T1 weighted 3D image. And that's kind of pretty much sine qua non, which you can now appreciate along with the T2. So kind of running through it here. That's a classic example. So look at the uterus per se. The uterus does have a normal morphology, but it's got certain features which can tell you what the pathology. This is a fibroid. That's a fibroid. So you're not worried about those two because they're pretty well circumscribed, sharp zone of interface. You have a normal junctional zone. So you know this is not adenomyotic. But the first thing which comes to your mind is you look at what's happening along the posterior wall. And what you see is the endometriotic tissue at the torus has kind of tethered the rectum. It's kind of puckered it. You can see those beautifully seen bands, which are seen puckering the rectum at multiple sites. So you don't need to get just one thick band. You can get numerous bands. You can see that within that area of puckering, you can see these areas of T1 hyperintensity which are developing. These are all blood of varying stages. So you know this patient has got a posterior compartment, a mid compartment and a posterior compartment rectal involvement, which is started to develop. Interestingly, if you look very carefully, I always try to look in these patients whether there is involvement of the rectovaginal shelf. This is the rectum. So please don't confuse this signal, which you see within fecoid matter, to be that of endometriotic tissue. You got to be very careful. The rectovaginal shelf is located here. And in this case, I don't see any endometriotic tissue within the rectovaginal shelf. Now let's look at the anterior wall. And this is where you see the change in contouring of the anterior wall as compared to the posterior wall. So here, look carefully. Normally, the smooth contouring should be like this. This is how the contouring should be. It should go in and come in like this. That should be the normal contouring. What's happened in this case is there's an acute upward tractioning of the tissue, simply because there is thickening, which is seen at these sites. I'll just identify the thickenings for you. That's a thickening, that's a thickening, that's a thickening, that's a thickening. And you can see now this kind of intermediate T2 signal soft tissue, which is kind of bridged the supravesical space. So thickening on the corpus, utrovesical space, which is a potential space of the inframesocolic peritoneal space, has been obliterated. You can see that the peritoneal reflection has kind of been now tethered to the structure. And now you can see how this tissue has gone through and through and taken apart the posterior superior aspect of the bladder dome. Now here, this is normal thickness of the muscle. So you can appreciate the normal thickness of the muscle, which is seen here. That's normal thickness of the muscle, which is seen here, of the bladder wall. You can see that inner mucosa. You can see the intermediate layer of the muscularis and the outer layer. Here you see that lack of zonal differentiation. You can see that not only has the lesion taken out the outer surface, but it's gone and taken out the full thickness of the bladder dome itself. Interestingly, what has happened is this patient did not have hematuria. And if you note very carefully, and if I show this, and let me just see if I have, oh no, I don't have a post-contrast here. But if you look very carefully, what has happened is this so-called inflammatory reaction in the bladder wall, which is transmuscularis, has incited a mucosal hypertrophy, and which has caused a so-called undulating or a pseudopolypoidal appearance, what we call as bullous hypertrophy of the bladder wall mucosa, which is a secondary or an epiphenomenon of the muscularis infiltration. Now let's move this on the T1 weighted 3D, and you can now start appreciating that the disease, which was initially transmuscularis, has now gone all the way up to the mucosal surface, and you can see specks of hemorrhagic tissue which are seen within. So this represents the anterior cul-de-sac pattern of the deep pelvic endometriosis. That is bladder wall involvement, utrovesical shelf getting affected. If there is indeed any, I don't see any obvious utrovesical shelf deposits sitting lower down out here, but I can see that the supravesical is obliterated and the bladder is now tethered to the corpus itself. So this is the anterior compartment. So I've finished the mid. I've shown you some examples of the posterior. I've also shown you now the classic anterior compartment disease itself. Once you're done with this, sometimes patients who have got this typical mid involvement or even a posterior involvement may undergo a hysterectomy to get rid of the symptoms. But when you have a pathology which is not only confined in the vicinity of the corpus, but can get disseminated either on its own into the peritoneal space or can be iatrogenically disseminated, you need to follow up these patients who undergo hysterectomies for these kind of pathologies. And many a time the pathology tends to recur, and the classic site of recurrence is usually at the site of the vaginal stump and the upper third of the vagina involving the vaginal wall. So here we have a patient who has come with the classic appearance of a recurrent disease, which is seen at the level of the vaginal vault. So I'm going to magnify that image on the T1 weighted 3D fat suppressed image, gradient echo sequence. And you can see this kind of a ball-like structure which is sitting up in the vault. You can see how the vault is kind of retro-tipped. It's kind of pulled back again. And within this so-called ball-like structure, you can see this internal variegation with some amount of T2 shading where the T1 brightness is seen. And this is again a vaginal vault recurrence of an endometriotic tissue. But that's not all. When disease does recur, you also need to know that it can have the same propensity to invade the adjacent structures as the primary disease itself. And here you have the classic involvement of not only the vaginal vault, the rectovaginal shelf is kind of infiltrated, and you can see how the disease has gone through and through the rectovaginal shelf and has started to infiltrate and has invaded the full thickness of the rectal wall itself. The length of involvement is easy. That's a straightforward 3 centimeter length of involvement. That's sizable rectal wall involvement. And if you note very carefully, this is below the level of the peritoneal reflection. So this again fits into the classic deep pelvic endometriosis posterior cul-de-sac pattern of rectal involvement, which is sine qua non of this kind of a pathology. Let's see how this disease kind of behaves on the multiphasic contrast sequence, and keep your eye on glued onto the rectal wall thickening. So that is the rectal wall thickening. And when I run my contrast sequence, you can appreciate how the lesion has kind of produced that typical mushrooming appearance. You can appreciate the mushroom which is coming in. So this out here, if I were to, is the classic mushroom appearance of the lesion, kind of arcs down. That's the lesion in the rectal wall. It's kind of breached the mucosa and the muscle layer and is producing the typical appearance. And you can see how overlying that full thickness muscle invasion and the some degree of mucosal, you can see the hypertrophied mucosal lining kind of wrapping over that, because that's how much of inflammation does endometriosis produce and kind of inside. Also, what you need to do is that whenever you see areas of enhancement like this, you need to make sure that there are no skip areas of involvement. So that's a classic area which you may have to raise an index of suspicion of, which is hyperperfusing within the rectal wall. And this could be a sign of recurrent, not recurrent disease, but multifocal disease, which is affecting more than one segment of the same segment of bowel, or more than one segment of that bowel loop. So it could be rectum, it could be colon, it could be anywhere. But multifocality is 2 or more sites of involvement in the same segment of the bowel loop. So you need to be very careful that you don't miss tandem or skip lesions. Now, another clue that why there could be infiltration which is so low down is you can appreciate the blackening of the anterior wall of the lower rectum going up to the level of the levator shelf. Now, this again is usually a good marker to say that disease was there at some point in time and is now just coated or left a kind of a hemorrhagic and a fibroinflammatory imprint of itself on the surface of the rectum. Of course, the invasion is little more rostrally located. You can see that it starts from the superior most edge of that black line and goes up all the way. When you see this on little more later phases, the dynamic contrast, you can see that all those areas of enhancement are all suspicious and have to be taken with a significant amount of consideration. That here you have chronic fibroinflammatory changes which are non-enhancing on the early phase. Here you have active disease within the rectal wall, or kind of the mushroom cloud appearance, which you're seeing here, and the multifocal areas of enhancement within the vicinity of that fibrotic scar all need to be very carefully looked upon. What else do we need to see in these patients? Whenever you get vaginal vault or vaginal remnant involvement, it's pertinent also assesses where else can that hemorrhagic deposit be. So you can see this beautifully, how those hemorrhagic deposits are seen in this case just beneath the fibrous scar in the anterior rectal wall. But it's the duty of the radiologist to ensure that there's no disease which is skipped and has gone all the way into the vulva and therefore into the anterior and the posterior fourchettes. I won't be showing too much of that today because of the time limitation. But that's again a very common site where you can get to see vulval endometriosis secondary to the deep pelvic endometriosis invading the vagina. So that's an important structure to remember per se. I'll kind of show you all a couple of more cases, and then probably I'll end the session. So the first battery of cases, if you look carefully, had the typical uterine involvement, the ovarian involvement, and of course, I've shown you all the rectal, I've shown you the vaginal, the recurrent vaginal, as well as the bladder involvement. So I've kind of covered the entire gamut of pathologies which affect that location. But there's an important gamut which is now known. So I've gone from peritoneal to a subperitoneal, or what you would say, some people would call it retroperitoneal. There are two gamuts of the pathology which need to be looked very carefully upon, and that is the extraperitoneal nature of the disease itself. So one of the classic sites of extraperitoneal involvement is the pelvic side wall. So here you had a patient who was presenting with recurrent radiating pain to the right lower extremity. The history itself is very typical that the pain is going to be cyclical. Every time the patient gets a menstrual cycle or a periods, she would be having a flare in the symptomatology. Sometimes the pain just persists through and through, but sometimes the patient would just die. The pain would just die off with medications or with the typical suppression medications which you use in these patients. And but more and less, the pain used to be typical, menstrual associated, cyclical, radiating pain. And of course, over a period of time, the pain would become constant simply because of the amount of cicatrization. So as I had shown you all yesterday, the lumbosacral plexus is a conglomeration of two major nerve trunks. The first one is the L4-5 lumbar plexus, and the other one is the S1 to S4 nerve plexus. So you have L4-5 and S1 to S4, and this is the typical location at where you identify the lumbosacral plexus in relation to the posterior aspect of the obturator internus, posteromedial, you would say, arcing along in relation to the piriformis itself. So that's the left piriformis. That's the left piriformis. You can see that the piriformis divides the greater sciatic notch into a superior and an inferior compartment. I won't be getting into all those nitty-gritties onto the anterior divisions and the posterior divisions. You can read for that through any of the websites which are available. But here you have the classic appearance where the individual fascicles, so you should see the individual fascicles like this. These are the individual fascicles of the nerves. You can see that beautifully here on the left side, but on the right side, you can see that typically behind the obturator internus, you can see this mass-like area, pseudo-mass-like structure, which has got a very variegated signal of T2 darkness with some areas of gray and of course some bright signal. So now let's go and see what this looks like on the T1 weighted image. So I want to put all these sequences all up for you. And on the T1 weighted images without fat suppression, this is the T1, this is the T2. The areas which are kind of blackish on T2 are blackish on T1. Areas which are grayish on T2 are grayish on T1. So you know this is fibroinflammatory. And the areas which are bright on T2 are showing brightness on the T1 weighted image. So now you need to confirm whether this is hemorrhage or this is something else. And on the T1 weighted fat suppressed sequence obtained before giving contrast, you can now see that all those areas which are bright on the pre-contrast T1 are not are not getting suppressed on the fat suppressed sequence. So these all represent hemorrhage. And this is a combination of both active and non-active chronic fibroinflammatory desmoplastic or cicatrization, which has occurred due to the presence of recurrent bleed in an endometriotic tissue. Now, this endometriotic tissue can affect not only the plexus, but can get into the retroacetabular portion of the plexus into the sciatic nerve. And what you start to see is, due to the recurrent bleeds, that there is denervation neuritis, which has happened in the muscles which are supplied by the lumbosacral plexus. Ideally, these are muscles which are in relation to the pelvic girdle, to the hip joint, and of course, then you start to get weakness in the lower limb extremities itself. So if I were to show you a single T2 weighted image without fat suppression, and I would kind of just mag the image, you can see that there is asymmetry in the muscles itself, starting from the obturator internus, that's the Alcock's canal, which contains the pudendal nerve. Here you can see the obturator externus sitting up at this location along with the gemini, and these are your gluteus muscles, which you can see up here. And you can see a differential area of signal intensity. The bulk has reduced. You can see that the gluteus has kind of wasted. So when you're looking at these pathologies, you need to know that they not only affect structures anatomically, but they have a functional implication as well. And you can see the secondary changes of denervation in all these structures. So please do remember that denervation neuropathies are not just a pure function of nerve damage, but it could be due to extrinsic factors also causing changes in the endo and the perineurium of these nerve fascicles. So please remember, deep pelvic endometriosis is one of the causes of radiating pain in a woman of childbearing age when everything else is clear, and also a cause of chronic pain, and of course denervation neuropathy and myopathies over a period of time. So that's the classic lumbosacral plexus involvement. I'll probably just show you one more case for the sake of completion. So here you have a patient with a kind of a retrotipped uterine corpus. You can see that pretty much out here. You can see that the junctional zone is normal. You can see that the endometrial cavity is normal, but you can see that the endometrial cavity is kind of tented a little more in the front, and you can see a lower uterine scar in this location. So when you have a lower uterine scar in every patient who's got a lower uterine scar, it's pertinent that you actually see that there is no tissue which is hemorrhagic within the scar itself, because that could be a sign of scar endometriosis that is within or in relation to the C-section area. So here you can see these areas which are T2, showing T2 star shortening. Now this is susceptibility rather than anything else, which is seen here. You can see susceptibility from air, and you can see susceptibility from surgical clips as well. So when I'm running the sequence, I'm pretty much confident that there's nothing which is T1 hyperintense at the scar. But something catches my eye when I look at this, and on the T2 weighted image, on the lower portion of the posterior aspect of the corpus, I see a couple of areas of blackness and brightness intermingled with each other. And very carefully, if I note, I can see a nice thin sliver of blackening on the corpus itself. Now, the patient had non-specific abdominal pain. And when you start looking at this, you start realizing whether post C-section there was ectopic implantation or iatrogenic implantation of endometrial tissue into the pelvic peritoneal spaces. Now, ideally, what would happen is when there's scar endometriosis, you would see T1 hyperintensity at this location, and then you would see the endometriotic tissue over the anterior surface of the corpus. But many a time we don't get to see that, and that typically spills over in the cavity, and usually it sits into the area of the rectouterine pouch itself. And now that's a classic location. And when I go onto the T1 weighted three-dimensional sequence, I start appreciating the involvement of the rectouterine, the anterior peritoneal reflection and the posterior surface of the corpus. And what do I start seeing? I start looking at these areas, and if I'm running through them gently, you can see that there are areas which are showing T1 shortening or T1 brightness interspersed among those areas of very low T2 signal. So I go onto my actual images just to verify what I'm looking for. I come down to the level of the corpus, and you can start now appreciating these areas of brightness which are now seen in relation to the corpus itself. So all these bright areas are very, very concerning. Let's go back onto the standard T2 weighted images of the patient, axial, and voila, not only do you see black signal on the surface of the corpus, you now appreciate that the ovary is also plastered, and there's evidence of an ovarian endometrioma. So this is classic post C-section endometriotic tissue spilling out. But what else do we see? Patient had local tenderness in the left iliac fossa or in the area of the hypogastrium. So this is very important, that whenever you're having surgical or post-surgical states and patients presenting with non-specific abdominal pain, which is not related to the hollow viscus, it's pertinent for you to use the entire gamut of imaging to make sure there's no evidence of endometriosis. And especially if they ask you that this patient has had a uterine surgery, it's better for you to not do CT, but migrate to MR. And you can just do a non-contrast MR and look at all the possible sites where you could have implantation of endometriotic tissue. So you can see that this is the level of the phalansteal incision. It's typically in the infraumbilical parietus. It's a horizontal scar which kind of arcs on either side of the midline or a little more laterally, anterolaterally. And now you can see why the patient was having focal pain at this point. So here you have your T2 weighted image, and this is your T1 weighted fat suppressed sequence. And bang on, what do you see? You see an iatrogenic endometriotic implant, which is now sitting within the bulk of the rectus muscle, the left rectus abdominis muscle. You know that the transversalis fascia is the only facial reflection. You don't have a posterior rectus sheath below the level of the umbilicus. It's kind of deficient at that layer. So you have the rectus muscles along with its three major components, the external, internal, and the transversalis. You know that the posterior rectus sheath is deficient. And this structure out here is actually representing the properitoneal fat plane. So you can see this properitoneal fat plane beautifully. This is the properitoneal fat, and this arrow is actually the peritoneal reflection. And you can see how there is iatrogenic endometriotic tissue at the scar site in the parietus. And you can see that this endometriotic tissue has puckered the peritoneal reflection. And you also note that there is a thin twig which is extending from this puckered peritoneal reflection into the bowel loops. So you not only have scar endometriosis in the anterior parietus, you have the scar endometriosis infiltrating the properitoneal fat, infiltrating the parietal peritoneal reflection, and also tethering a small bowel loop at this location. So please remember that whenever you have surgical planes in relation to the uterus, it's pertinent for you to identify all these surgical planes and make sure there's no evidence of disease at any other site. So with this kind of, I've shown you the entire battery of presentations. Let me see if I can get you all one more case. So probably it's just not time enough. I'll just refresh this with one classic case just for you all to show, kind of complete the entire spectrum. So you have an anteverted antiflex uterus, which is kind of looking normal in size, but you can see the change in the contour. Please remember that thing, change in contour, thickening on the serosal surface. It could be anterior, posterior, or fundal, but this is a classic posterior thickening. You see the retrotipping, the retraction, the concavity, the thickening at the concavity itself. So the depth of the concavity should have the thickening. Within that thickening, you can see glands, which can be hemorrhagic or non-hemorrhagic. So this is hemorrhagic, and you can get non-hemorrhagic glands, which are slightly lower down here. You see invasion of the subserosal posterior myometrium. You can see that altered signal sitting up here. You can get dilated endometrial glands here. This is pseudoadenomyotic because the normal junction zone is completely spared. You can see that because of disease involving at this location, it's in very close proximity to the torus uterinus and the uterosacral junction. You can see that the posterior wall and the fundus are retrotipped. There's tethering of the rectum, and there is full thickness rectal wall infiltration. Interestingly, what has happened is there is submucosal fat proliferation, not just edema. What you're seeing as bright is not bright, but you can see that on the T1 3D, the area has got completely suppressed. So you know the patient has had chronic inflammation involving the rectum. So you have the typical mushroom appearance with submucosal fat infiltration. And secondly, what else do you have? You have both ovaries, which are now not ectopically located within the pelvis or above it, but both are located in the parauterine space. And you can see this beautiful plastering, what I call, or adhesions, and the frozen pelvis, which you can see in this location. This is a classic DPE mid-cul-de-sac pattern, frozen pelvis, rectal wall invasion. So with this, what I've done is for about 80 odd minutes, I've taken live cases on the entire spectrum of pelvic endometriosis. Of course, there's lots more, which I don't have enough time on, and hope you had an enjoyable time learning. So with this, I kind of end this entire 4-day session on pelvic floor, on MR defecogram, adenomyosis, and deep pelvic endometriosis. Okay, so thank you very much for patient listening. Okay, Madhu, I'm done.